Okay, we're here in Houston, Texas with a panel of AIA, Applied Integration Academy professionals.
Woo.
I'm just going to have everyone introduce themselves just so we can get familiar. James, let's start with you.
My name is James Anderson. I'm from St. George, Utah, and I'm grateful to be here in Houston. I travel to Houston twice a month to be here for a couple of days each time to be a part of the AIA experience and be here with Dr. Alice Lamb.
I'm Dr. Alice Lamb. I'm a dentist in the area, or you might call it a recovering dentist. I look at the whole body in relation to the head and neck and the bite. And I was blessed enough to meet this group, Mike and James, and learn so much about how the body influences the bite and the head and neck, and vice versa. So
I don't want to talk about myself. Mike?
I'm Mike Cantrell. I'm from Georgia, and James and I have been partners for quite a while. And then I came to Houston about 5 years ago at the behest of a dentist that I work with in Atlanta. And so I came to know Dr. Lamb, and then we started working with patients. And we started getting really crazy busy. And so I asked James to get down here and asked our good friend Dr. Wise to get down here. She and I have worked together for a while in Georgia, but we need all the help we can get because the academy continues to grow like a weed. So it's been a real pleasure seeing that occur, and it's because of folks like you who have expressed such a strong interest in the science.
I'm Dr. Heidi Wise. I'm an optometrist, and for a long time I've been working with people like Mike and James and trying to use the way somebody sees the space around them through their eyes to change how they move their body. And through working really with Dr. Lamb, I've come to understand how important everything that goes on in the oral cavity and in the temporomandibular joints is to what I do. So now I really can't treat patients without PTs and dentists already on the team. So I'm kind of the last frontier when patients can't get to where they need to be with the other two modalities.
and she is considered our secret
Sauce. I was waiting on
Yes.
that. She's the secret
She's our
sauce.
secret
That's
sauce.
what
Totally.
Yeah.
All right, so what I did was proposed to YouTube in particular that I'm going to be here, and while we're here, we could take the opportunity to sit down and just answer some questions from the community. So the way YouTube comments work is that you can upvote a comment or a question that you think is good. So the most popular ones are the ones that we're going to answer. And depending on how deep we get into rabbit holes, we'll get maybe an hour or so in. That might give us room for 6 to 8-ish questions. So let's start with the most popular ones. The one that got upvoted the most was from Flying Fox 09. I'd like to hear about how bite or teeth not lining up in the bite can cause tension in the jaw and potentially propagate down the body. Also, how a narrow upper palate can cause the tongue to no longer seal or sit correctly, causing sleep issues and snoring, as well as contributing to jaw tension.
Wow, that sounds like the question either from a dentist or a malfunctional therapist.
I would agree.
Yeah, it's
That's
a
a
great
very,
question.
very great question.
And it's
Very-
kind of two separate questions in one.
Totally.
One is about the palatal width, or that concept and how a tongue can go up, and then the other one is about habitual bites versus what we call a body-centric bite. So there's a difference between the two. I can
Let's have
keep
some fun
going.
with this,
yeah.
Mike. Why don't I let you answer about the bite, because he's about the body,
Yes, and so
and then I'll fill in if you want me to. but-
okay. So when I start
Yeah.
to say something that excites you,
Okay.
jump in. All right. So everybody here. All right. So I'll start to talk about it, and then you dive in.
Yep.
So the first thing that I want folks to understand is that teeth are really, really exquisite proprioceptors. They tell us where we are in space. So teeth can agree with my body about where I am in space, or they can disagree. Oftentimes, what happens in mouths is we'll try to orient our teeth in a position. See, I'm being really careful about how I'm choosing my words here. We'll orient our teeth in a position that we'll refer to as a habitual bite. So that's the bite that you kind of know and love, but it may not love you. So you're putting your teeth in a position for full occlusion, meaning full contact, the best way you can get them together. Now, the downside of that is potentially that position that you found creates tension somewhere in the body. Sometimes in the old TMJ, sometimes with facial muscle, sometimes with body muscle. That contact that you've made tends to be biased on one side or the other, or a little forward or a little back, and this depends on your teeth themselves, and it depends on the body position. So let's just say, for example, that we all agreed that a person had a bite that was habitual, that wasn't necessarily helping them. Our first line of attack might be to take them out of that bite. So by putting some space between the teeth using a device we call a PATA, or a pattern altering dental appliance, we might put that PATA between their teeth and adjust it in a way that biases or convinces their body to change position, because we've changed their original habitual proprioception and given them a new proprioceptive influence based on the PATA, not on their habitual bite. Well, what that does is it allows a body to relax and let go. And so we'll see a person no longer in their habitual bite, finding what we would call a body-centric, newly created bite. And that would allow a physical therapist like me or James to work with that newfound body ability and train that body to no longer need the device. Oftentimes when someone is taken out of their habitual bite, courtesy of a PATA, they'll discover, for example, if they wore it through the night, they might discover when they remove it in the morning that their teeth don't meet right. Well, that's because they've been out of their habitual bite for so long that now overnight, that their teeth are hitting funny. Well, my teeth hit funny now. But then within a few minutes, eating breakfast, brushing their teeth, going through the morning routine, suddenly they're back in their habitual bite. Now that might cause them a problem, or it might not. But what we're going to try to train them to do is ultimately not need that appliance to help them no longer be habitually finding a bite that drives them into a pattern. Now, if we flip it, and this is what happens in the world of orthodontics. In orthodontics, what happens is sometimes a patient will be given a pretty bite. Well, that's the goal of orthodontics. Let me have a very pretty bite. So the patient gets a beautiful,
aligned
nice
smile,
aligned.
teeth, but not necessarily the hills and valleys of the tops of your teeth can meet.
Correct.
So now they're having to use more muscles just to make it fit.
Or it does fit beautifully on a crooked body.
On a crooked body.
So I could now have the teeth seal this person's fate, because now I've taken a bite, created a nice straight set of perfectly fitting teeth, and suddenly the patient is reporting neck pain, back pain, hip pain, foot pain, shoulder pain, knee pain, all of these new pains that we as practitioners don't associate with the orthodontics, because the orthodontists just straighten teeth. So they feel like my work's done. And then, a year later, they're coming in reporting all sorts of trouble. So we have to be careful about putting straight teeth on a crooked body, or having someone learn to adapt to a habitual bite by crookedizing, is that a word?
Crookedizing.
Their body.
Well, Mike, what also happens is when those people get their braces off, they oftentimes, if they don't have one of those permanent retainers, their teeth go back to being a little bit more messy. Why does that happen?
Yeah.
Home run out of the park, what you just said, because that was a research project that we published at the American Equilibration Society last year. So that was 2023. And in that poster presentation, we had two patients in a subject study, right? We took two patients who had an upper lingual retention wire. We tested them, and we saw bodies that were very, very off, and patients who had a lot of complaints. So then,
One of them was actually your partner.
yes, that's right.
Jacob.
So we cut the wire, and then immediately following removal of the retention wire, we saw a body completely change. And that was stunning to see someone go from right hemispheric occupation, or really lateralization, to suddenly fully left hemispheric lateralizing.
What do you mean when you say that?
I knew you were going to say that, and somebody there is probably going to say the same thing. What are you talking about when you say right lateralizing or left lateralizing? You want to take it?
Well, the body tends to move into different patterns and can take the different regions of the body, like the neck region or the rib cage and breastbone region, or the pelvis and sacral region, and shift and turn and compress them in different directions. First with normal movement. Before we talk about dysfunction, we have to talk about normal function. Normally, the three regions of the body, the pelvis, the rib cage, and the neck, should shift and rotate and orient themselves rotationally together to one side. And with that, the person's bite scheme and tendency to bias and contact their teeth on that same side should naturally happen with all those body movements. The cranial motion, the cranial strain, the cranial sequence should travel with that. So we should have a body that together moves in one direction and a cranium that moves with it in response to what the body does to the neck and what the neck does to the head. Naturally, our bite should go to one side as our body goes to one side. And then as our body pattern reverses and our bite pattern reverses, we're able to access the other side, and hopefully we can keep all those three regions together when we go from side to side and create and use something called grounding through the teeth and also through the floor to keep the body pattern unified as he goes right, and then use that grounding and the ground reaction force from the ground and proper muscles to rotate the pattern the other way, and use the bite and the body on the other side to get back into the ground on the other side. So it's really a grounding dance, but it's also a body pattern rotating from one side to the other dance, and it's a cranium shifting and rotating in opposite directions with that body. So I should have a normal cranium working with a normal body. The challenge comes when the pattern starts to become non-intact in different regions of the body, go in one direction or the other that doesn't match a normal sequence, or when their occlusal state isn't matching a normal contact sequence that goes with that body sequence. So bites and bodies should move together to activate and achieve the ground, and then bites and bodies should go the other way to activate and achieve the ground on the other side.
So James,
When any of that gets dicey, then we have a problem.
So going back to the original point, if you have a crooked bite on a body that is doing something that doesn't align with that bite, you have a permanent retainer in, that's going to lock you into that position,
Yes.
right?
Yes.
So how does that play into it?
So when we say the cranium, really there's 22 bones in the skull, and the bone in your palate, your maxilla, there are really 6 bones, or 3 bones with 2 halves. There's the premaxilla in the front of the palate, then there's the maxilla across the middle aspect of both sides of the palate, and in the back of the palate, the very back part of the palate, the part facing the furthest away from the teeth, you have the nasopalatine bone. So there's a nasopalatine right and left, a maxilla right and left, and a premaxilla right and left. There's really 6 bones separated by a midline suture. All 6 of those bones need to be able to naturally dance. Now they don't separate, and they don't pry apart, and they don't do weird dysfunctional things. They stay very integrated through a central suture, but they need to be able to move and dance like this freely across all 6 of those bones across each side to keep things unlocked. So when you put a wire or a dental appliance of any kind that's restrictive up into the palate, you take wherever those 6 bones happen to be dancing, or the proverbial the music is playing, and then when the music stops, they catch you, and wherever they catch you, if they put a device there or a wire there, wherever that palatal position and cranial movement has gone will continue to drive the body wherever that movement tends to drive the body, and now the wire in your upper palate is causing a body to be in a twist and a shift that just isn't comfortable for normal living.
The exciting thing was putting that at AES, at the American Equilibration Society
That was
meeting,
awesome.
posting that, because here you had 500-600 dentists seeing this kind of concept for the first time. They were like, wait a minute, so there's a relationship between that wire and what bodies do? And we were like, yes, and that excited them.
And
So
then
much
a couple
so.
months ago, we followed up with a case where we had a 13-year-old scoliotic child who went through 2 years of PT, and I'll show you the pictures so you can share it with the group. After 2 years of PT, they couldn't unlock her scoliotic curve.
Yeah, they
It was
couldn't
like a
reduce the curves.
46-degree scoliotic curve. Well, when Mike and James saw her, the first thing we saw is she's in braces. And Mike's like, there is no way that we can unlock that scoliotic curve if she's locked in braces during that time. So
it echoes the lingual wire that you're talking about.
Yeah.
In this case, it just wasn't a lingual wire; it was on the front.
And they were working it. Luckily, her father's a dentist who was following our work, and the orthodontist was gracious enough to say, "Hey guys, take care of what you need to take care of for your daughter. Come back to me when you're ready for me." And so we took
Which
the wires out.
should be the gold standard.
Yes,
That's the gold standard.
Absolutely, it's that collaboration.
Ultimately, it will be.
Yeah. And so she came back and we put in an ALF, activated light wire functional appliance, and the ALF freed up her cranium, freed up the maxilla, the premaxilla, nasopalatine, like James said, but it wasn't just those bones. When you free up 6 bones, you actually really freeing up 22 bones connected to it.
And then there's a spine.
And there's a spine.
that many
and when
more.
you're freeing it up, what you're allowing it to do is you're allowing cerebral spinal fluid, which is the brain fluid, to move between the left and right hemisphere and come all the way down to the spine. And they taught her how to change her airflow. And we actually, in 3 months, corrected her scoliotic spine from a 43 to 26 degree curve or something like that.
43 degrees to 26 degrees is stunning. That's beyond statistically
In 90
significant.
days.
In 90 days from that x-ray to this x-ray.
That's incredible. Well, I guess that leads us into talking about the ALF a little bit. The palate. So that's the second half of the question, which is, how does a narrow upper palate, which is something we see all the time, cause the tongue to no longer seal or sit correctly, causing sleep issues and snoring, as well as contributing to jaw tension? It might be good to introduce the concept of the ALF along with
Yes,
that.
yes.
Keep talking. I'm going to check the battery on this camera, but keep going.
Okay. So I think the question not necessarily is how can the tongue fit that palate? The real question is, how did the palate get to a size where the tongue can't fit the palate?
That's what I was thinking, the same thing.
And so how did that palate get that way? Came from development. There were usually the palate and the size and the shape of the palate is developed by the function of the tongue. So that begs the question, was this person restrictive since childbirth? Did he or she have a tongue tie from childbirth? And sometimes, you can find out, I know we're in a time period where women work, and so we don't get to breastfeed our children as much. It's not just the milk that feeds the baby some good stuff. It's the action of the suction. And that action helps the tongue to develop and do what it's supposed to do by creating a mature tongue swallow. In doing so, it creates the entire palatal vault. It creates not just a palatal vault, but the tongue coming up to the roof of the mouth develops the entire airway. The reason is because the tongue has to sit at the roof of the mouth. And when I say sit, often people goes, oh, it needs to be at the roof of my mouth? Let me shove it up there as much as I can. No, because the natural tongue position has to come up and lightly drop down, forming a suction between the palate and the tongue. Because the roof of the palate is the floor of the nasal sinus. So when it forms that suction, the nasal sinus gets to come downward, which opens up the nasal passageway for the development of airway. Children that don't get to have this early on tend to have chronic ear infections, enlarged tonsils, because they're not really getting the air filtered properly in order to have clean air, and so they'll get inflammation. And I've seen many times that when we're able to produce lip seal, tongue to the roof of the mouth, and a nice suction, oftentimes you'll see that tonsil shrink up on its own.
So I want to dovetail something
Sure.
onto this. So when we're talking about that palate, so really it's not that the tongue didn't fit in the palate, it was the palate grew in a way that prevented the tongue
Yes.
from rising. And then there are the palates that are more than adequately wide enough, but still the tongue is dysfunctional and not from a tie. And this is where I'm going to pull you into the conversation. So now you're thinking, he's about to turn to an optometrist as we're speaking about tongues, but I really want you to roll with this for a moment. So we had 2 crystal clear presentations, one of which didn't need an optometrist, that we and had frankly been working with a great myofunctional therapist for quite a while. And this was actually posted on AIA Instagram. And on that Instagram post, it was really about learning how to quiet the anterior neck through establishment of a proper diaphragm position that allowed the tongue to rise into the palatal vault effortlessly. So that's one case. The other case, the same sort of work took place with a myofunctional therapist, then with a PT who understands rib cage dynamics, but the tongue still wouldn't go up into the palatal vault. So what did we do? Well, of course, we called an optometrist. So I want you to talk about that case, and it also is on the Instagram account. So it's, if you want to go look, you'll see it. But go ahead.
Yeah, so in that particular case, the way that the patient was using their perception of the space around them visually was hardwired in to keep their body, including their cranium, including their tongue, from learning appropriate movement. They couldn't move air properly through their nasal cavity. They couldn't have good suction from the tongue at the roof of the mouth, because the way that they see the world around them kept them in one locked position. And no matter what we tried, we couldn't get them out of it. So eventually I changed the way that they see the space around them, which short circuits all of the autonomic function in the body, including the way that you hold yourself up against gravity and breathe.
So are you saying that we could have a habitual bite, but we could also have a habitual sight?
Absolutely. And in fact, if the airway developed narrow, if they did not have full oral development because maybe they didn't breastfeed, or maybe there were early developmental problems that went on
Like
that
tongue
prevented
ties,
this,
buccal
a tongue
ties,
tie,
lip ties.
the chances of them having more significant visual issues to complement that are high. So the longer the developmental dysfunction has been there, the more likely vision is a piece of it.
So can I ask one more quick follow-up then?
Absolutely.
So why can't we just then make the palate wider? Why can't we use a palatal spreader and RPE, that palate, rapid palatal expansion, on a case like that?
Because the roof of the mouth is the floor of the eye sockets.
So
And
it's
if
not just
you-
the floor of the nose,
nose.
it's the floor of the orbits.
And so if you start rapidly moving bones, the 7 muscles around each eye that are attached to 4 different skull bones, they're going to know it. And you're going to change not only the function of each eye separately, but the function of the 2 eyes together, as well as the tension on the little eyeball globes themselves, which can rapidly do some funky things to prescriptions in a compensatory manner, because the eye muscles are trying to figure out what to do when they were so rapidly put in a different position.
Heidi, this like just freaks me out, because you know that dentists right now are the leaders truly in airway. And we are proud to be leaders in airway. And we've done so much stride in creating all kinds, from MARPI to SARPI to Vivos, and all these wonderful work that my colleagues and I have done to help people gain airway.
Mm-hmm.
But now you're saying that the eyes affect that airway, and I'm learning that from you, and I'm thinking, how do we get this into the work that we do, so that thereby, in trying to help patients with one thing, we're not creating another? Where
And I think
where
a big
can we
piece
fit
of
into
it
that?
is doing things more slowly and allowing the body, by training the muscles differently, to allow the bones to move. Letting the body be responsible for bone movement, rather than devices forcing bone movement and then expecting the muscles to try and reorganize around something that's very foreign.
And
that
what
occurs
if,
very
what
rapidly.
if, so I can see that in kids growing up, you can develop it. In adults, yes. In older adults who have high morbidity in airway, and they desperately need this, we have to go in for surgical.
Mm-hmm.
I mean, so how do we manage it so that we mitigate the side effects, or if you want to call it that, where vision comes in? Is that something that we should engage an optometrist to look at the space and the way vision sees the space around it, like you said, before and after our surgery? Is that something that
Honestly, it's very difficult as an optometrist, even doing what I do for so long, to measure the way someone sees the space around them.
Okay.
So the way I measure it is by having these guys put their hands on a patient and see what their body is doing, and then see how that changes when we ask them to consciously recognize space differently and or force them to see it differently through changing their lenses. So I can't directly measure the way they appreciate the space around them. It's reflected in what their body is doing.
I see. So somebody who's already in body-centric and moving fairly freely will less likely to maybe have visual issues?
Less likely, as long as they don't already have visual complaints that would reflect instability, eye teaming problems, or a history of fluctuating, rapidly changing prescriptions. Those are all signs of a not stable visual system. And if you rapidly change that, you're definitely going to have a more unstable visual system, and the fallout's going to be greater than somebody who says, no, I don't have any problems with my eyes working together, my prescription's been stable for years, if they have any at all. I don't have problems keeping my place when I read. I don't get motion sick or car sick. You know, you can't, as an optometrist, tick off any of the boxes that reflect, hey, I've got a problem with how my eyes kind of process the world.
You know, most people, including dentists, because we're not eye people, when we think of vision, we just think of, you know, a sign 20 feet away with the lines.
letter
2020.
Basically 2020. Can you help distinguish for our audience a little bit more? Because I've learned so much about that from you. That it's not about sight. It's about vision, and there's actually a difference.
And that's really, when you go in for an eye exam, sight is really what's being checked. Do you have the ability the eye doesn't have any pathology, the brain doesn't have any pathology. In other words, there's nothing physically wrong. So maybe without glasses, maybe with glasses or contacts, I have the ability to see 20/20. And I have the ability to detect motion out here in all sides of my vision.
So that's clarity.
That's clarity and what we call peripheral vision. But just because we have clarity or we have peripheral vision doesn't mean that we use that in the best way to direct our body through the space in the world. That's what vision is. It's a reflection of what the body and brain are doing with what the eyes tell it.
That's good. I think we should move on to the next one. And I think that naturally, both the dental and visual component of tips for TMJ. So, little TMJ discussion. What do you guys view that as? What is commonly the problem? And what are good solutions?
I guess that would be my question. I can say that about 75% of my TMJ patients come post-orthodontics. Not to say that orthodontics does anything wrong, but the amount of strain that goes into the cranium in moving teeth, I think is great enough that it causes a lot of muscle reaction to that strain. And if the body can't move well, and I've never considered this when I was doing TMJ work prior to meeting you guys, but when the body can't move well because we're locked up in the cranium, I think it puts a lot of pressure on the joints. I've also had TMJ patients that have come in while in braces, and they're having massive TMJ issues. They even tell me they can't breathe, that they hurt right at the sternum. I get a lot of that. Or sometimes they don't even know, so they don't think it's from the dentist or from the orthodontics, but they happen to tell me at a hygiene visit. Other patients that come in, they get locked jaw. That's pretty common as well, where they can only open up a little bit, and they usually will wake up with it. And previously, my take on that would be airway, because you're clenching and grinding at night, you're doing a lot of it, and you're basically damaging your joints, and so the disc ends up becoming displaced, and you get locked jaw. Now I see things very differently, because I believe while we do clench and grind at night, I am seeing the clenching way more daytime. And there's a lot of daytime clenching and grinding. It's just as dentists, we don't really ask. And it's hard for us to give patients a bite splint and say, hey, wear this daytime. Because people just don't want to wear it daytime.
What is clenching and grinding to you? What is that telling you?
Clenching and grinding in the past tells me that somebody has a habit of clenching and grinding either because they're anxious or nervous or, have anxiety issues, but that is so far from the truth, okay? I've learned now that I'm understand more about the body that clenching and grinding is an effort to control airflow. It's the body's effort to help air flow in a body that's so restrictive that airflow is not helping. And so people will use their head and neck, activate all their muscles, sometimes anterior, sometimes posterior, sometimes both, and they clench and they thrust their tongue down and forward in order to lift this rib cage so that they can get better airflow because they're restricted. And Mike, you do that body thing really cool. Can you show our audience?
Sure, yeah. One of the things, yeah.
I can't do that thing that
it's
you do.
not always, as we already know, it's not
Yeah.
always an airflow issue.
Right.
And it's more of TMJ has always been thought of as this orthopedic problem where you've got a socket, a ball, and a disc in between, and there's a relationship that's bad. And so you start getting derangement or damage to one of these three structures.
Right.
The ball, the socket, or the disc, or
disc.
all of the above. And so, yes, that's it's like having a bad hips ball and socket. Ooh, I need a hip replacement. And in the world of dentistry, they'll say, well, orthopedically, there's some damage here. Let's operate. Well, we're less inclined to say that if we understand that this is an orthopedic problem that's brought to you by a neuropulmonary occlusal dysfunction. And so if we take it down the neural pathway and understand that the person who is damaging this joint is doing it as a result of a need for body position, like what we were talking about earlier with hemispheric occupation or visual hemispheric occupation. So think of the joint being damaged as ortho, and the cause of that damage is neuropulmonary. So then we go to the airflow concept and we think of, if we speak to the pulmonary part, I'm going to activate my anterior neck to elevate my rib cage. Now, what you have to think about is, if you've gone for a run and you really sprinted in at the end. Now, at the end of that run, you might get in a position where you're resting like this. Now, the reason you're resting like this is because the weight of your shoulder girdles is pulling down on your upper chest cavity. Now, that upper chest cavity needs to fill with air, and the weight of your shoulder girdles prevents airflow from getting into your upper chest. So you'll assume what's called a Brugger relief position, which unloads the weight of your shoulder girdles off the cupula of your lungs to allow for expansion in the upper part of your lungs. Okay, that's fine if you've finished a run, but if we could imagine that some people are unloading their shoulder girdles off of their upper rib cage to allow the upper rib cage to expand, but somebody's got to pay the price. So when you do this, what you're doing is using the anterior neck and posterior neck to raise the shoulder girdles off of the lungs to allow expansion, and that creates a down pull on the tongue and jaw. So what you then have to do is clench the teeth to support this effort that you're doing. Again, here, my hands are unloading me. Here in life, with stress, I'm using my neck to do it. And if that's the case, somebody's got to pay. So I'm clenching my teeth and thrusting my tongue to lift my shoulder girdles off of my rib cage. That's pulmonary. Then there's the neuro component of it. And the neuro component of it would be if I can find a position with my teeth that'll help me leverage everything, like body position, then I'm now bruxing or clenching my teeth to support the entire machine, irrespective of respiration. So now I'm neurologically leveraging, but that neurologic leveraging of my body for position is creating damage at the joint. Or is it neuro and pulmonary, and half the time or 3/4 of the time, it's always yes to both. Now I've created what we have sort of collectively referred to as respiratory neurodontics, and proper respiratory neurodontic behavior unloads a TMJ. And that immediately gives people relief that they otherwise wouldn't have had, and they don't need to have the surgical intervention But if I'm a dentist and that's all I know, and again, like you said earlier, it's not a slight on the dentist. It's this is what they know. Patient's got damage, let's operate. Think about it again at the hip. The orthopedic surgeon who does a hip replacement says, there's damage there. It's not quite ready for surgery, so come back in a few years when it is. But what they didn't say was, it's not quite ready for surgery. You better learn how to change the mechanics of that ball and socket by getting with some therapist who knows how to control respiration to teach you how to unload that hip properly. What's the difference? There is no difference. So we have to learn how to unload this just like we have to learn how to unload this. There's no difference.
Beautiful.
Yeah, and that speaks to my career as a dentist. I'm in traditional, my old traditional dentistry mindset was of orthopedic origin. So when a patient comes in and tell me that they brux a lot, in my mind, okay, they have bruxism. Either we really don't know what it's coming from. It's probably from stress. So we make an orthopedic appliance like a splint so that they can brux on it and not damage teeth. It takes the load off the TMJ a little bit so that they don't hurt themselves as much. And then we manage. And our management can be years. I have lifelong, like 20 years management of TMJ patients through splints. And I end up going to something that I call the splint black hole. And so when I met Mike and James and learn about this work, this movement science, I realized that the body is contributing. And it begs the question, why are they bruxing? And that's when I started to understand and realize it was a pulmonary, it's a respiratory and neurologic problem.
Yeah.
And so now we make something called PATA, pattern altering dental appliance, which looks like my traditional splint, but I no longer adjust it just to get teeth to be evenly adjusted and get the TMJ to be as even as the patient gets on that day, because they come in multiple times, get it adjusted all the time. Now we get our therapist to help adjust the human. And what I do is I go in and I make the appliance to a body-centric position. So Mike and James will get them their body in a centric position where they've got no restriction on either side. We take bite records on that and we make an appliance on a body-centric position.
Yeah, so that's a
Yeah.
joint effort at writing the prescription
That's right.
for how that device should be adjusted. So going back to the original question, like, if it's, hey, talk to us about TMJ, we're sort of saying the joint can get damaged, but there are reasons why, and they're neurologic and pulmonary and sometimes both together. There are devices to prevent that damage from occurring and normalize functional mobility. I mean, that's kind of like in one sentence.
Right,
Perfect.
but the devices don't really do the work. It's what you do with the device.
Yes,
As a team.
it's a permission slip for us to
Right.
actually treat the patient.
Right.
Mike,
That's
can
how
can I take your real simple example just for the audience? You talked about a ball and a socket at the temporomandibular joint.
Uh-huh.
When we see dysfunction at the ball and socket on one or both sides, we don't want to know just about the compression or lack of compression on that joint. We want to know which way that socket is actually
oriented.
facing.
Right, that's
And
right.
so our real question is, are the sockets facing the direction they're supposed to for the ball to fit in it? And if they're not, why?
So-
and then I go into your reasons
Yes.
why, which are there's a breathing body problem, there is a neurological grounding problem that pulls the body and the neck into a twist, that changes the cranium, that moves those sockets for the TMJ. And
So
it's about,
but you're committing complete heresy. You know that, right? Even
Yes.
saying that about the sockets, which we are 1,000% in agreement with, but that heresy of describing socket movement is what is latest and greatest and cutting edge science that you actually demonstrated on an Instagram post. And it was just, for me, it was so exciting and just music to my eyes when you did that, because what I saw was controversy, this controversial series of questions and, hey, but what about, and are you crazy? And it's like, crazy like a fox. I know exactly what's happening neurologically, But and it was like I almost wanted to go in, and everybody who was just screaming at that post, I want to go and shake their hands and go, I'm so glad this upset you. The same thing happened at American Equilibration Society. So here's dentists going, what in the world are you saying? Here are people in that post going, what in the world are you saying? And then James Anderson walks up and says, watch those sockets move. And the father of occlusion is a man named Pete Dawson, rest his soul.
Yep.
And 5 years
My
ago,
mentor.
I went into that AES with her and spoke to Pete Dawson because he did a big lecture on this TMJ and said, we finally know where the J, the
joint,
the
the
temporal, this condyle.
The M,
we
the
know
M
where
in the TMJ.
Yeah, thank you. The M of the TMJ.
mandible.
We finally know where it's supposed to sit, and we've been fighting about it for 30 years. I went up to him afterwards and I said, we're going to have to change the definition one more time. And he's looking at me like I have lobsters coming out of my face. And I said, we're not ever talking about the socket. And James Anderson is saying it just as casual as can be because he knows. But Pete Dawson said, what are you talking about? And now he was so excited to hear about this. And he was like, I want to hear more. Here's my card. Give me a call. We have to talk. Because he knew intuitively that this thing moved. But nobody came out and said the TMJ position is dependent on two things: body position and state of respiration. And that's it. And you just said it, just willy-nilly casual, like everybody knows that. But when we
No.
look at the controversy that was around that
No.
post you did,
Entirely controversial in dentistry.
Nobody
because
knows it.
we
It's-
are about condylar position. Has nothing to do with the fossa.
condyle, not fossa. And what we're saying now is it's Mufasa. Let's
Say it again. Say it
Mufasa.
again.
That's what
I love
it
when you
is.
say that.
That's how it
Heidi,
is.
do you have anything to add?
Well, of course. So the more neurological that drive is, the more likely vision is keeping the fossa in the position that it's in. So when these guys get a good dentist involved and she gives the jaw and the cranium the permission to move into the right space, and they either can't move there or they don't stay there, they move there but they won't stay there, that's when we know vision has probably gotten intertwined. The way they see that space around them is now responsible
Yep.
for the position of that cranium and therefore the position of the fossa.
And either dentists out there or, our friends who are your friends watching this, if you guys are moving jaw side to side and you have a hard time moving one side, try taking your eyes to that side, and all of a sudden, if your jaw's tracking, you know that the eye's controlling some of that. So
And you're
I've had to
getting
do that
too-
before in
yeah.
adjusting splints. If somebody doesn't have full mobility, I'm like, well, I wonder if there's a visual control of this. Can you move your eyes to the left? All of a sudden, their whole jaw can move.
I want to know what the next question is. I'm curious. I got to know.
Time out. We got to switch the batteries.
All right.
So I think given a lot of this conversation, people and maybe parents and orthodontists, dentists are going to be at home and asking, okay, well, I'm hearing a lot about braces, but what if I have people and I want to straighten out their teeth? Like I have people and I just want to make their bite nice. Like what is a better alternative? Like what do I do with these millions of people that want to fix their bite? What's the solution then?
All right. You want to go?
I don't think there's anything wrong with doing that, but you have to know what the person's predisposed to. Because I know as dentists and orthodontists, you've been in cases where you do the exact same thing on two different individuals. Why is one person symptomatic and the other person's not? It's because in our training, we're trained to not look or even ask questions below the neck. And if they already have issues of breathing or hip discomfort, knee issues, plantar fasciitis, what we do, we own the control center. We as dentists, we own the control center of the body and everything below. And so I think we have to understand the body, and dental education has to start speaking about the body's relationship and influence on the bite, and more importantly, the bite's influence on the body as well. And so people get sorry.
I just want to make sure we're still recording.
Oh, okay.
I was like, did I click record? All right, go ahead.
So So I don't think there's anything wrong if there's not a predisposed. We've been doing orthodontics for a crazy amount of years. Okay, and we have straightened up and brought a lot of beautiful smiles, not just beautiful smiles, but with straight teeth comes great periodontal health, just self-esteem, mental health, so many things that I think that we are capable of.
And Alice, and straightened out a lot of bodies in the process. We want
Yes.
to make that clear. I think the good orthodontic work that's been done historically has helped take many a cranium and neck and body where they need to go, because the guidance of the occlusion came back to a balanced, normal, natural place
Yes.
that optimized body health. So that
Right.
happens way more often than not. And it's just such an
And they don't
important-
even know, they don't even get
They don't know
the
how
credit
they need that.
of what
need-
they've done.
They absolutely need credit
Yeah,
for that
we don't get
in every
credit
way.
for what we've done. And at the same time, if we knew a little bit more about the body, it can also be more predictable about the issues that can come up when you're trying to take care of somebody's body. If they already have some of these body misalignment, not stacked well issues, then we could actually foresee that and avoid a lot of problems that can be very hard on the patient. Because if they come back to us and say, ever since I've been doing this, I can't breathe, I can't do, most dentists will think, well, we should go get a sleep study because this maybe it's about something else, without realizing that us, putting all this strain and force on the cranium could be causing airway, airflow issue below the neck, body movement issues below the neck. So
I think orthodontics itself is a wonderful thing. And like you said, for years it's been a wonderful thing. I think that as the science moves forward, we'll see instances. First of all, orthodontists, as they're greeting a new patient and beginning that process, they need to know more questions to ask
Yes.
of their patients. And that's where the academy comes in, because the academy teaches orthodontists what questions to ask as they're dealing. Like you were just throwing out some questions. And so an orthodontist who might be listening to this might go, wait, what did she just say? And it's those questions that an orthodontist needs to know to ask. And then you have the situations where the orthodontist has to have red flags reeled up the post. Like,
That's right.
do you have a significant scoliosis? Yes. Well, then I need to think twice about putting you in braces. What's your Risser score? What's your Cobb angle? And do you have a physical therapist? And are you in a spinal brace? And if the answer is yes to the yes and no's and the degrees of curve and my Risser score is low, if an orthodontist knows to ask those questions, can you imagine them asking
Yeah.
that? Like, they don't know those
and that's
questions.
on children. On adults, what if you have a bulging disc or herniation of your disc, whether it's in the C-spine or
the L-spine.
lumbar? It matters.
So
Because
those are
us
questions that they need to
doing
ask.
what we do in
Yeah.
the mouth can actually negatively affect that.
So it would be awful for someone like us to say, orthodontia is bad. That's just the dumbest thing in the world. It's a wonderful science and that has done so much. What we should say is orthodontists are great. Here's how we can make that science better. And here's how it can help more patients. And here's if they understand things like an ALF and how they can use an ALF to promote growth and development, they can avoid that first round of ortho when the kid's a kid. And then give them their second round of ortho where it's actually brackets and wires or Invisalign trays or whatever. So I think it's just the ortho needs to learn the questions to ask. And they're all hungry to ask the questions. They're just looking around going, who's going to teach me the questions? And that's where this research comes in.
You mentioned the ALF, and that's something that we've all been working with in this visit to Houston, and you guys have been working with the ALF for a long time. Alice, would you mind introducing what an ALF is and
Sure.
why we like it and what its purpose is?
Sure. So ALF stands for Activated Light Wire Functional Appliance. And in my practice, my patients call it the amazing life force. I would second what Mike was saying before. It is not an orthopedic appliance. It's not there to move teeth, move anything. It is there to assist the neurological and respiratory component of body. Even more so, it also regulates the autonomic nervous system in ways that have not seen any dental appliance or any dental modalities to do. I was really, really against trying to do anything with wires. When I first met Mike, he goes, "Have you heard about the ALF? You know, I really want to get involved, and I want dentistry to be part of this, and I heard about this ALF, and I've worked with this ALF, and I really need you to learn how to do the ALF." And I'm like, I'm not bending wires. I'm not an orthodontist. I don't want to do wires. And now it is my favorite thing to do in my practice is the ALF. Because this ALF has been mind-blowingly, is that
We're going with
that's
it,
a word.
mind-blowingly.
It's been mind-blowing, and it's been life-changing, and has brought me such a sense of purpose in helping my patients with this. For me, I call it my lightsaber, because it is absolutely magical. So what it is a wire. I've got mine right here, and this wire that we normally see, we recognize as orthodontics, or just any layman person looks like an orthodontic retention wire, or one that you can bend to move teeth. However, this is not it. It is made out of a special wire, and this special wire is called a gold alloy wire. And if you just touch the wire, there's a vibration that exists. It's very springy. And it's in the springiness, what it does is it helps to relieve the sutural joints between the cranial bones, and it unlocks it. James was talking a little bit a while ago about the cranium dancing or moving. And it dances with every breath that you take, every move that you make. And so that dance of the movement of the cranium is so important in moving cerebral spinal fluid, which is the fluid that bathes your brain and your spine, allows it to cross midline and come all the way down to your tailbone. So in doing that, it does so much. I mean, if you start looking at cerebral spinal fluid movement and the resonance and all of that in that's a rabbit hole that we don't have time for today, but I'm like totally nerding out with that lately. I love it because I'm seeing it in action when patients come back after wearing this, and they feel less brain fog for the first time.
We had one today.
You had one today, yes.
Mm-hmm.
And we get it all the time, so it's almost, it fills me with such a sense of purpose when I work with this. And what I do want to speak out to is for our dentists out there. Okay, we were taught in our dental education that what we do with our hands is what brings value to who we are and what we do as a profession. But what I've learned with this is that it's not what we do with our hands, because it's how we guide the patient to do what they need to do for themselves that I think really truly brings us value. And when I got involved with learning about the ALF, I truly learned to value my care, my skill, and my judgment, and creating that relationship with the patient to be observant enough to know what they need. So this ALF, I'll give you an idea. You see these 3 omega loops, and Connor will shoot it up so that you can see closer on this. But this omega loop, what it does is it creates a mature tongue swallow. What a mature tongue swallow looks like is when you swallow, the first thing that happens is the tops of your teeth should come together and touch the molars, okay, a molar area somewhere. If it's not touching a molar, there's an issue, okay? If your tongue's in the way, if you're touching a front tooth and you don't have molar coming together, that's an issue that needs to be looked at. But in a typical tongue swallow, the tops of your teeth should come together, and it will touch one of these one of these rests that we create on here. And what it does is creates this micro vibration in the ALF. And these omega loops that is formed there starts vibrating, and just very, very, in a very small way, just vibrates and opens. And what that does is it unlocks the cranium, okay?
Does it push them apart, or does it
No,
just free
no.
them?
This is a springy light wire functional appliance. That's why it's called ALF, activated light wire. So the light wire only unlocks the cranium. Now, there's been a lot of misconception about the ALF, because people will go in and say, hey, this looks like a palate expander. Let me go in and use my dental training and my hands that I spent many years and cranked this open because maybe I need to unlock the cranium by cranking them apart. No, this is not what it does. What it does is unlocks the cranium, so one that has a high palatal vault where the sides are very steep. Typically, those are brought to you by, the body and the rib cage and the movement of the rib cage. I'm not going to go down that rabbit hole, but there is a reason why it's that way. And with the tongue not functioning where it's at, the body pretty much placed it there. And so when you wear an ALF like this, what it does through the tongue swallow is it unlocks, and you end up getting expansion by unstraining the cranium where it comes out from the bottom rather than cranking out the top. And so when it does that, the teeth come with it. So you may have different teeth position, but the teeth, that's position. But because I don't crank this open and the tongue places it there, the teeth come into a place that we call the neutral zone in dentistry, which is a zone on the dental arch that's dictated by our lips, our cheeks, and our tongue. So if it's in a neutral zone, that is the healthiest place for you to take it. Now, in orthodontics, in early orthodontics in the 80s, we used to remove, whenever we have somebody with crooked teeth, brought to you by a vaulted palate because the tongue did go up to develop the cranium or the arch, we used to pull teeth, like usually 4 of them. And then we would take teeth and we would retract it. So those are man-made ideas of where the teeth should go. It is definitely not dictated by a body position place. And so it worked really well. We got a lot of pretty smiles, but you know what else? Today, we got a lot of sleep apnea patients that came out of that. So, I think we have to learn from our past where we use what we do to dictate science. Now I think it's time that we start to understand the human body and help the human body dictate where teeth are supposed to go, for example, where airflow is supposed to go.
So I want to jump in here for a second
Yep.
about this and just mention that it was a little over a year ago when we were in California at the Breathe Institute, and we had a chance to visit with Derek Nordstrom.
Yeah.
So for those of you who don't know Derek Nordstrom, he's the person who he invented the ALF. And when we had an opportunity to visit with him
At the Breathe Institute?
Yeah, at the Breathe Institute in Calabasas, there was a nexus moment, and it was that he was realizing that our understanding of the ALF as a neural reprogrammer and a device that assists people with airflow was something that he had been shouting from the rooftops for years, because he knew that this device was not a palatal expander. And for those that confuse it as a palatal expander, the originator of the device is screaming it is not. And to that end, he has been really trying to make sure that it's out there and understood that it is not a palatal expander. Next week,
There have been a couple of horror stories. So when I've talked to people about the ALF, they go, whoa, hang on. That thing's dangerous. It's a bad
Exactly.
idea. Don't do that. You're a criminal for bringing that up.
Yes.
So let's talk
Because-
about that. So that is because there is a school of dentistry out there that believes and uses the ALF incorrectly. That is not that ALF Synergy Academy Derek Nordstrom side of the house. It's what we call the BALF world, or the bastardized ALF. And in that world, the use of the ALF, see, I'm a PT, I don't have a dog in the race. What I understand is that if you're using an ALF as a palatal expander,
And
you're driving
using
up the wrong...
orthopedically to move teeth and
Yeah.
try to push bone through teeth. That's not what it's designed to do.
If you did that, then whoever says that is right. I agree with them 110%. They're right. That is a dangerous thing to use. But an ALF used correctly is not. I have a young lady who was incorrectly handled with an ALF, who was treated poorly with an ALF, and now she has an ALF in her mouth, and it's been the best thing she's had in her mouth. So we've got living proof in an optometrist who was taken down Balf Lane and realized very quickly, as her teeth were moved out of the bone irresponsibly, that now with that recovery and then going down an ALF pathway a la Derek Nordstrom, what we see is a wonderful rejuvenation of corrected movement. And that, she's a living example of both sides. So she could 100% agree with the person who says, don't do that, it's dangerous. Mm-hmm. And she's a living example of a refutation of that very thought, because when it's used correctly, it's a wonderful device. But keep in mind, the most wonderful device on earth is only appropriate for the patient for whom it's appropriate.
Yes.
So chemotherapy is great on someone with cancer. It doesn't really help anybody with a cold. So likewise, I can't take sinus medicine if I have cancer. I need chemo.
Totally.
So
well said.
It's always about patient selection.
Yes, and what I do want to point out about that is the ALF is not a dentist-activated appliance, okay? It is not
Well
dentist.
said, that's right.
It is a body-activated appliance, and when you free the body so that the tongue can do its job, the tongue will use the ALF. All it does is enhance what the tongue's capable of. And it starts developing the arch, developing the airway that was misdeveloped or missed opportunity to develop earlier on in life. And we develop the entire, people say, well, you can't really develop after, childhood. That's absolutely wrong. You continuously develop throughout your whole lifetime. You may not develop as quickly, as fast as children, but if you guide the human into better body patterns, better motion and freedom of movement, this is a tongue-activated appliance. So how can you get in trouble with what you're talking about if your body put it there? Mm-hmm. If a healthy body puts it there.
And for me, doing what I do, that appliance saves patients from A, needing me quite often.
Right.
And B, when they do need me, I have to do bare minimum to them to change the way they see space, because their cranium is already being neurologically unlocked and their tongue is already starting to do what it's never had the responsibility and ability to do. So it provides a large step forward before I ever become involved with patients, which means they spend less time with me, they have less distortion of space around them when I change them, and they're out of my program much less time, much less lens changes. It just goes so much more smoothly, and I get so much more out of a visit in patients that are appropriate that have one of those in their mouth.
And I know people get confused also because there's ALF, there's AGA, there's all these, acronyms. Appliances. And AGA has had some bad rap because I think it started out seeing something like Derek Nordstrom's appliance, but like misapplying it.
100%,
in an orthopedic manner,
and
then getting in trouble with it, and then changing the wires, changing the design.
Totally.
It is not the same thing. If you are seeing somebody who says they're doing an ALF and they're not working with a body specialist of some sort, whether it be a PT or an osteopath, you're really not getting an ALF.
Person.
You're really not getting an ALF. If
Yeah,
it's not a body guided appliance, it is not an ALF.
That's the best way to put it.
Mm-hmm.
All right. I think that was great. So one thing that I think people really want to hear about is exercise. I have a couple of broad questions here. We want exercises. Another person says, I'd like to hear about exercises that actually work, and more importantly, about those that don't. And so I think what they're alluding to here is like, all right, so I'm at home, and this whole process sounds like a lot, but what are some things that I can do myself? What are some exercises that I can do, or, strategies that I can do that will help me with some of these issues? Is that even possible? Are there things the average person can take away from this conversation and implement in their life, or do they need to work with someone who's qualified?
I think the answer is a little bit of both
Yeah.
to that last part. They could take away some really great concepts, and then they could also seek out an opportunity to learn more and become more proficient at properly diagnosing what the body needs so they know how to provide the training for that body. Earlier I mentioned these body patterns and the tendency of a body to pattern in one side or the other, or to rotate one part of their body in one direction and maybe another part of their body opposite that, and just get in a skewed or a dysfunctional pattern. Our goal is to get what the cranium needs and does to naturally and appropriately complement and feed into what the body needs and does. And so I have the three regions of the body shown here on this Rubik's Cube. They may move into one hemisphere, and they may compress well on one side and feel the ground well on one side. And if I know that the body has a restriction and is stuck like that, it's easy for me to know and appreciate that I need to take these three regions naturally in the other direction with
What
the
are the
goal.
three regions?
Thank you. The three regions that I mentioned earlier are the pelvis, and this bottom row of the Rubik's Cube says sacrum. The rib cage and the breathing mechanism is the middle area that I spoke of, and this row says the sternum, to be at the middle of the rib cage and breastbone. The breastbone is the sternum, and then the top one is the neck, or the middle neck. Segments C3, 4, and 5. These middle neck segments can help us appreciate what a body is doing under a cranium. And if I can sort these three regions out correctly and diagnose it correctly, then I can prescribe the exercises correctly. Now, with that in mind, and building on Connor's question, this is an example of an AIA spectrum of lateralized patterns where we depict 6 patterns on the left side of the body and 6 patterns on the right side of the body. And then there's 2 types of patterns that are not typical, where one body region may go one way in a pattern, but in the same pattern, another body region may not follow the pattern and may go another way. So those are called non-intact patterns or broken patterns. And so those non-intact patterns have several variations. In fact, each side there are 6 variations. So we say there are 6 patterns, but 2 of these columns have 6 variations. So in truth, there are 16 patterns. Now, I don't want that to sound more complex and confusing than it should, but I also don't want it to sound more simple than it need be to be able to successfully understand exactly what you're working with. So it's nice to appreciate generally what people need to do well in a hemisphere, getting in and out of one side with where their body needs to go. But not everybody follows the simple rules of being a simple law-abiding right hemispheric pattern or a simple law-abiding left hemispheric pattern.
Yeah.
And so what we've done at the Applied Integration Academy is we've been bold enough to tackle all of these potential patterns, try to simplify them, reel them in, and help deliver them in a way that gives trainers and physical therapists and other body movement specialists the opportunity to know what they're dealing with, so they're not trying to provide a solution that doesn't fit the problem. And Mike, we talked earlier about this gait and grounding course that's coming up in June in Oregon.
In Portland.
And in I think September in Florida, and again in December in California and San Diego. In that course, we'll take the opportunity to break down specifically how we get to the diagnostic criteria of which pattern a person is in. I don't want to get too into the weeds with that material, but when we need to get into the weeds with a given client, we want to have those solutions.
I wanted to summarize something. And it's to the question. If on the one hand, you've got lots of specificity, and it's like, you need an appropriate diagnosis in order to issue or assign appropriate treatment, i.e., give me the appropriate exercise. So on the one hand, we need very, very much good specificity of delivery of an exercise. But then on the other hand, it's like, okay, come on, help me not overthink this. Like we were saying a second ago, it's like, just give me some meat and potatoes here, which I totally understand. One thing that people can do first off, you've been doing a bunch of stuff just on your feed, on your Instagram.
Can I touch on that for a second?
Please, I want
the
you to.
self-assessment that you're doing for people,
Yeah.
that's extraordinary. I
think
it.
I think it's really easy to listen to this conversation and go like, oh, what do I have? Like, this is like a big issue. I identify with a lot of this, and I need to get seen by these guys right now.
Right, and I just don't want to go there. It's
Not
like,
necessarily though. Like, you don't. a lot of this stuff is complicated, yes, and it's hard to like self-assess and identify, but a lot of the content that I and you guys will start to put out is really designed for the average person to see if there's someone that doesn't have a complex situation. So most people should be able to go on my YouTube channel and do a little bit of a deep dive and, you know, understand what's going on with their body to a certain extent. And I would say the majority, but not everyone, can see some benefit.
See, I totally agree with that.
But, you know, there are people where it won't work and they'll start to question, okay, does this guy have any idea what he's talking about? Do these exercises have any merit whatsoever? And the thing is like either A, what's likely is you're either not able to do the exercises, which are complicated, and I understand, and I totally sympathize with that. It's hard for the average person to look at my YouTube channel and go like, oh, okay, I can totally do this, this, and this, and without any other coaching on my own other than listening to this guy's voice. That's really hard to do. But secondly, what's also likely is that you have something else going on and you can't figure it out by yourself, and you need to see someone about that. That leads us into the problem that we're in today, and that is that this stuff is kind of in its infancy. Is that fair to say? Like, this is kind of new stuff. So it's not out there enough, and we need more professionals, more
We've been
dentists.
accused of being called biohackers.
Yeah,
I
no.
didn't even know what that was. But to me, it's not biohacking. It's just going back to the lost art of physical medicine.
We need more personal trainers. We need more dentists. We need more physical
PTs.
therapists taking these courses and understanding that. I'm not trying to say that selfishly. I'm just trying to say that because I've seen what this stuff can do. And I've seen just by being here in Houston a couple of times just how incredibly powerful it is. Like today, some guy said, my brain fog is completely changed. I can now memorize something. I can memorize a numerical sequence, and I've never been able to do that before.
Yeah.
It's incredible what this stuff can do, and there's just got to be more people out there learning about it, and it'll happen. But right now, I'm a little frustrated because I hear people ask, "Where do I go?" And I'm just sitting there like, right now, I don't really know.
I'm frustrated because we have a lot of patients that need us, and some of them are in so much pain they call begging us to get in, and we need more PTs. We need more PTs all over the country.
All over the world.
We need more
We have them
dentists.
reaching out from everywhere.
We need more optometrists who are interested in joining our effort to this new area. You said infancy. This is what we call physical functional medicine. It is an area that is a collaborative effort between movement specialists, dentists, optometrists, podiatrists, myofunctional therapists to all come together and see the human body as a unified whole rather than separate parts. And in doing so, we get issues resolved, and way quicker than what we were doing in our own silos.
Let me just say something to the physical therapists out there, of which James and I are both. We have right now dentists screaming for AIA trained physical therapists. And so I just want to beg you to please avail yourselves of the material that we're offering you, and we can put you in touch with these dentists. You can immediately start working with a dentist who is hungry for your arrival. So it'll keep us off a plane and keep you gainfully employed.
What's the best way they can do that?
By reaching the first thing they should do is go to the AIA website and enroll in probably gait and grounding. And as you mentioned a minute ago, there are 3 courses in gait and grounding right now. Get that done, get Body and Bite under your belt, get Body and Sight under your belt, and get the Master's Fellowship. At that point, when you've completed that, you are good to go. And I would feel very comfortable about those individuals being out in the ether and us referring them. Our website blows up with patients and with dentists seeking physical therapists. I can't make it any more clear than that. Going back to the original exercise thing, if I was somebody that was looking at this, the first place I would go is to your website. And I would go to your Instagram feed, to your YouTube, and I would just start watching that. Because they are so crystal clear and simple to follow.
Yes.
And I would initiate myself with that and just try to take some of those tips and treat myself. I'm either going to be successful or I won't. And if I'm not, it's not because this stuff doesn't work. It's because my diagnosis goes beyond that scope. Now let me move to the next level. And then come and see guys like us.
Totally.
And then we can then move them through, and then simple stuff is going to work with these folks. So it's not that complicated. The first thing anybody does when they've got a problem is they may have injured themselves. So the first thing they do is say, well, let me stop doing whatever it was that I injured myself. And that could be enough. They didn't do anything. They just rested and they got better. Great. The next step is maybe take some anti-inflammatory drugs or something. Okay, now you're better. Maybe not. Next step, let me try some of this simple stuff. Oh, that got me better. Maybe not. Next step, go and see some guys like us. Oh, that got me better. Maybe not. Next step, go into more invasive procedures, and we know who to send them to. So it's not hard. So it's just a simple progression through the steps. First stop is just look at what you do and follow the instructions. It's like a cookbook.
Yeah.
It's not hard.
Try to make it as simple as I can.
And you're doing a good job
Great
of it.
job.
I don't want
we
to sound
appreciate you
gratuitous,
so
but it's
much.
just
You
good.
helped a lot of our
Thank you
patients.
guys. Yeah.
Yep.
Let's go. We have a couple minutes left.
Sure.
Let's go more rapid fire. So let's try to answer some of these questions in like a minute-ish or less.
Okay.
Elevator speech answer.
Yes.
Okay.
Totally. All right. How is bite and all of this stuff we're talking about negatively influenced by a missing molar or wisdom teeth removal, or you just missing a tooth somewhere?
You would end up losing grounding
With loss of molars.
with loss of molars.
You know, the old rule of thumb is at least give us 1 or 2 molars to work with.
Molars
Griffin.
are important, guys, because if you notice, animals with 4 legs, they have teeth when they come out of the womb.
Yeah, they can stand right up.
Yeah, babies, they don't really walk well or have stabilization until their 6-year molars come in. Adults, they lose balance when they lose their molars. Molars are really darn important.
Cool. Okay. I've seen a couple of questions. This one in particular is good. I'd love to hear more about the effect on the rest of the body, mainly the influence on the pelvic floor muscles. How is the jaw related to the pelvic floor?
While the jaw is directly related to the pelvic floor, at AIA there are 3 regions as I've outlined, but more importantly there's 3 diaphragms that need to function well. The pelvic diaphragm, the front of the pelvic floor, and it works well if the glute max orchestrates the position of all of the muscles and bones and structures in the pelvic floor region for success. The respiratory diaphragm is maximized with the abdominal musculature putting the respiratory diaphragm where it belongs. I want that pelvic floor, that respiratory diaphragm, and then what we call the mandibular diaphragm, the floor of the mouth.
That
and
is
the
an
tongue.
AIA term.
That
This
mandibular diaphragm, that the tongue is the glute max of the cranium. And when I have dysfunction at a tongue and cranium, I have dysfunction at a glute and a pelvic floor. And when I give a glute and a pelvic floor the function they need, I actually do worlds of good to give a cranium and a tongue what they need. And when I get all these things charging together and working like they should, it's golden. And when they're dysfunctional, it's a mess.
I would tell any pelvic floor physical therapist, if they're dealing with pelvic floor dysfunction, they have a duty and an obligation to investigate the mouth.
Okay. Awesome, guys. Mewing. What about it? What do you guys think?
I don't have a big,
Mewing is great.
yeah, it's like, why would I have
mean, John Mew was ahead of his time. Now, some of his modalities, I'm sure he would agree today, he would have done things a little differently, but for the most part, he brought attention to where attention was not being put on.
But why doesn't it work sometimes?
Because
It's not a
because
standalone.
mewing stands alone with up here, not looking below the neck.
It's the opposite of that pelvic floor statement we said a second
Yep.
ago. If you're a pelvic floor therapist, you're not dealing with the mouth, you probably aren't. You're going to have fewer successes. No, if you're just dealing with the mouth by itself, I've never seen a mouth walk into a clinic alone. It
I've
comes
never
with a
seen
body.
a pelvic floor walk in the clinic without a head and neck.
If that ever happens, we need that documented because I want to see that case.
What if you have a tongue tie? How would that influence mewing and the outcomes of it?
Yeah, well, you wouldn't be able to do to perform any of the mewing exercises that they have.
You can't
Tongue
mew if
ties
you've
are
got
a
a
big
singularly
deal
elevated
nowadays
ribcage.
because we're starting to understand it more. And most people think, oh, I don't have a tongue tie. I speak just fine. But tongue ties and speech have, you can't use speech as a way to diagnose tongue ties. But I'll tell you, there were a lot of questions about TMJ. It's very rare that I get a TMJ patient that doesn't have a dysfunctional tongue somewhere.
Or a pelvic floor problem.
That's
What is, quickly, like, summarize the problem a tongue tie has on all this stuff we're talking about?
Tongue tie, I would say probably the most powerful thing a freedom of a tongue can do is give you nasal breathing. If you've never read a book called Breath by James Nestor, you'll understand the power of nasal breathing and its association with the autonomic nervous system, the cardiovascular system, respiratory system. I mean, you name it. Nasal breathing is almost everything. And what contributes to functional nasal breathing the most is the tongue.
Mm-hmm. Got it.
So,
Okay.
is that helpful? Is that what you're asking for?
Totally.
Okay.
Is surgery the only solution to fix an overbite?
How old are they? It all depends.
I don't know. They have a cartoon as their thumbnail.
It depends.
The first there's never the word only in anything. Yeah. So the easy answer would be no, it's not the only solution. But then that's followed with, well, what is? I mean, the follow-up question to the, well, what is how significant is the need for that correction of the overbite? I'm thinking of a patient exactly in my head right now who was told she must have maxillofacial and mandibular advancement surgery if she's ever going to get rid of her pain. Her pain was her neck. We put an ALF in her mouth and her pain was gone. So it's like, and it was the easiest patient I ever treated. And so the dentist was mystified at how this thing got rid of her pain. Well, she could have certainly had maxillofacial mandibular advancement surgery, and she might have taken that retruded mandible and moved it into a better position. For what cause? She didn't want surgery, and she said, all I have is pain. Why do I have to have surgery to get rid of my pain? I said, I don't know that you do. Let's see. Let's try something
if you
easy.
Understand the human body more holistically, with a whole body approach, you have more options.
Exactly.
There's no one or two, one option that's right or wrong. You have options. What's right for you may not be right for me.
Correct.
And that's a scary place for a patient to feel like there's no other option but to get forced into something like a surgery.
Yes.
Well said, because that may be the genesis of that question. This may be somebody who's thinking or has been told, you must have surgery, and he's going or she's going, is surgery my only option? The answer to that is no. You look at somebody and then help them make a decision.
And it depends on what their goals are.
We might go, hey, based on what you need and what you want and what you look like, yeah, surgery is your only option. Mm-hmm. We may say, no, surgery is not the only option.
Awesome. All right, last one. Sutures. How can we gain some mobility in them during adulthood, more specifically the tongue influence on the suture of the upper palate? And can we correct facial asymmetry by mobilizing the sutures and correcting muscular imbalances?
Is that a dentist asking that question?
I don't know.
That sounds like somebody who actually has already experienced seeing freedom of suture changing that. Because absolutely, yes. The other day, James, you and I we delivered an ALF, and right before our eyes, we had a patient with
an orbital cant.
For the last 17 years, she said. And we looked at her, and it literally moved in front of our eyes. And that's the first time. I'm not saying this happens very often. It's the first time I've ever seen it doing this. And James and I looked at each other, and we're like, did you see what I saw? Because, am I imagining it? And he was like, no, I saw that. I was like, thank God, because I thought I was imagining it. Yes.
The fast answers are like,
yes.
The better you breathe, the better the sutures move. The more free your tongue is, the better the sutures move. And if you can breathe, have a free tongue, and can shift your center of mass from one hemisphere to the other easily, you have the best likelihood of sutural movement, meaning
and
every
symmetry.
cranial bone, all 22, can then move. And if they're free to move, they typically are going to find a position of least resistance, which should be a neutral face. Sometimes you have to then go beyond what we do, and that would get into more like the facial orthotropics, which would be sort of the next step beyond neuropulmonary management, and getting them into something that can guide facial features into a better position. That's step 2. That's non-surgical. but it is more aggressive appliance therapy. It goes beyond what an ALF does. So there is that step. We know people who do that step.
Yep, and do it
So-
very well, very successfully.
really nicely. So that's something that people need to know. So first and foremost, it starts with learn to move, learn to breathe, learn to park your tongue in the right place. You should see some change. Percentage will, percentage won't. They go to the next step. Use these appliances. A percentage will see change, a percentage won't. Next step, more aggressive appliances. A percentage will see change, a percentage won't. For those that didn't, next step, surgical procedures. So there's always a next step. You don't just jump to surgery.
Great. Thank you guys. That was awesome.
Thank
Yeah.
you. That was
Thank
fun.
you.
Connor, thank you.
That was
Thank
fun.
you.
All right. That was great. Good stuff, guys. I think that will be very well received. And not by others.
I think you're gonna get
Good. Thank you.
some